Hey everyone, welcome to Micronutrients and Metabolism, Part 2. I paste the learning objectives into this PowerPoint, so just maybe review those from Micronutrients and Metabolism Part 1. This is just a continuation of that lecture. We're just going to look at a few more B vitamins and the roles that they play in our metabolic pathways. So we left off in Part 1 with biotin, and we'll pick back up with vitamin B6, which is often called pyridoxine. So pyridoxine is actually a family of compounds. We have pyridoxal, pyridoxine, and pyridoxamine. And we also have the phosphorylated version of each of those. So we have pyridoxal phosphate, we have pyridoxine phosphate, and we have pyridoxamine phosphate. All 6 of these forms are found in food, and depending on what form that we absorb them in, our liver will convert them to pyridoxal phosphate, which is the primary active form of this molecule. So pyridoxal phosphate supports more than 100 enzyme systems in protein metabolism, in particular transamination, where we might convert one amino acid to another non-essential amino acid. Also, we see PLP acting in red blood cell synthesis, carbohydrate metabolism, and the synthesis of some of our neurotransmitters like GABA, dopamine, and norepinephrine. B6 plays a really crucial role in converting homocysteine to cysteine. Homocysteine is a molecule that we find in animal meats. So when we consume animal foods, we have this molecule homocysteine in our body as a product of digestion of meats. And so homocysteine is indicated in like the development of cardiovascular disease. So as homocysteine levels rise in the body, that's one of the early indicators of the development of cardiovascular disease. So it's very important for our bodies to be able to keep homocysteine levels low. So important, in fact, that we have 2 pathways to degrade homocysteine. So B6 is one pathway we can convert homocysteine to cysteine. And then we'll see in a few more slides, folic acid, folate, and vitamin B12 can also change homocysteine to the amino acid methionine. So B6, folate, and B12 all play a really key role in this cardioprotective effect of basically changing homocysteine to a non-toxic form. Dietary recommendations for pyridoxine for men and women, for adults, technically 1.3 milligrams per day. And then as we age, that requirement goes up a little bit for men and a little bit for women as well. Because pyridoxine plays a really big role in amino acid metabolism, diets that are very high in protein tend to require more B6. Again, partly related to the elevated homocysteine levels that we see from high meat consumption. Good food sources of pyridoxine include pistachios, chickpeas, or garbanzo beans, pork, peanuts, salmon, and others, seafood, baked potato, and really that's any potato, but not really like potato chips. And so baked potatoes are recommended as generally the healthiest way to consume potato, lentils, and sunflower seeds. Toxicity with pyridoxine, again, very rare and generally only caused via oversupplementation. And if we do see toxicity, we can actually see irreversible nerve damage, and to a less severe extent, an upset stomach, headache, sleepiness, tingling, prickling, and burning in the skin. So an upper limit has been established for pyridoxine, and that's no more than 100 milligrams per day. You'll see that's quite a jump from the RDA. So again, not typical to achieve toxicity via food sources alone. We're really only going to see it if we're supplementing in pill form with this new. We will see issues with, as with all of our B vitamins, we'll see issues with pyridoxine deficiency. Again, it's relatively rare because pyridoxine is very abundant in our food, But when it does occur, what happens is a disorder called microcytic hyperchromic anemia. We might also see seborrheic dermatitis, neurological symptoms, and elevated homocysteine levels. The major causes of pyridoxine deficiency are actually alcoholism, which might be also characterized by cirrhosis and hepatitis. And then again, of course, would be inadequate intake. Folate. Folate is sometimes referred to as vitamin B8. We'll just call it folate, and sometimes I'll refer to it as folic acid as well. So this is a vitamin that's critical for DNA synthesis. Again, it acts as a coenzyme. Also acts as a coenzyme in cell division, amino acid metabolism, and the maturation of red blood cells as well as other cells. So all of these functions are basic for cell reproduction and growth, basic functions, which means then that this nutrient is essential for healthy development of the embryo during pregnancy. So we know that folate is very critical during pregnancy and even before pregnancy, making sure that the mother who anticipates getting pregnant has healthy folate status in her body, because this will significantly reduce the risk of neural tube defects. We will convert folate to a molecule called tetrahydrofolic acid, and this molecule has 5 active forms. We won't really go into more detail. Folate also works closely with vitamin B6 and vitamin B12 to support red blood cell maturation and red blood cell synthesis. And as we saw on the slide about B6, these 3 molecules collectively help to control homocysteine levels by converting it either to cysteine or to methionine. Recommended intakes for folate. Again, we talk about it in terms of dietary folate equivalents, similar to niacin equivalents. This is partly due to the fact that we convert it to tetrahydrofolic acid. So the recommendation for men and women 19 years and older, that's adult, is 400 micrograms, so now even smaller amount than milligram. And during pregnancy and lactation, that amount goes up to about 600 micrograms. And food sources include whole grains, and in particular dark leafy green vegetables. Folate, the word folate is derived from the Latin word for foliage. So thinking of your dark leafy green veggies as an excellent and rich source of this nutrient. One of the issues, potential issues that we put under the toxicity category is the fact that a folate excess folate intake can actually mask a B12 deficiency, because these 2 molecules work together so closely and in several different pathways like homocysteine regulation and red blood cell synthesis. If we're deficient in one, but we have sufficient intake of the other, this goes both ways. B12 can mask a folate deficiency, and folate can mask a B12 deficiency. So in the case where homocysteine levels are elevated or anemia is present, it's very important to determine whether it's a folate deficiency or B12 deficiency before pursuing treatment. As we've been seeing, as is commonly the case with these vitamins, we only see toxicity due to oversupplementation. And so more mild symptoms might be hives or respiratory distress. Because of this, an upper limit has been established, and that's 1,000 micrograms per day. Folate deficiency is a really important thing to look out for, again, specifically before and during pregnancy and during lactation as well. So causes of folate deficiency include inadequate intake, issues with absorbing in the intestines, so intestinal malabsorption, poor absorption from the intestines, increased folate requirements. So again, during pregnancy, we have an increased need. So if the woman is not increasing her intake before and during pregnancy, then we're going to see deficiency, And then other disorders like leukemia, lymphoma, and psoriasis also have increase a person's need for this nutrient. So one would have to be taking in folate above the RDA for your average healthy adult. And then certain drugs like sulfa drugs and anticonvulsants actually change our ability to metabolize folate. Some of them can interfere with the conversion to tetrahydrofolic acid. So that can cause deficiency. And then also prolonged diarrhea could also cause a folate deficiency because of overexcretion of folate. So there are there are 3 diseases or disorders to be familiar with regarding folate deficiency. The first is heart disease, again, knowing that insufficient B6 folate or B12 intake could lead to elevated homocysteine levels. Megaloblastic anemia could occur as well. This is where the red blood cells are not growing and maturing naturally, so they develop into these large and fragile immature cells, which we call megaloblasts, hence the name megaloblastic anemia. So mega meaning large. And because of their immaturity or their lack of complete development, these megaloblasts are unable to carry oxygen efficiently, and so oxygen transport to the body cells declines, and this would lead to fatigue and weakness, irritability, forgetfulness, depression, and even disturbed sleep. And then third is neural tube defects. So we saw this happens in embryonic development if the pregnant mom does not have enough folate intake. And it's folate intake throughout the pregnancy, in particular the first and second trimesters, which is why it's also important to consider folate status of the woman before pregnancy, because if she begins a pregnancy with low folate status, she's going to be trying to make up for lost time during the pregnancy. And so even if she were to regain healthy folate status by 1 month in, that's still 1 month of inadequate folate for the developing embryo, and so could lead to these neural tube defects. So what happens is that the neural tube is unable to fully enclose the spinal cord, and 2 defects that could come out of that is spina bifida and anencephaly. And then lastly, cancer is not a deficiency of folate, but there's been a lot of research over the past 5 to 10 years and possibly even longer looking at the role of folate in preventing cancer development. So using it as a treatment, or even potentially looking at is cancer more likely to develop where folate deficiency is present. All right, and then this is our last nutrient for this lecture is B12. So B12 is a group of cobalt-containing compounds known as cobalamin. Cobalamin converts tetrahydrofolic acid to its active form, which is just a methylated form of tetrahydrofolic acid. So it helps add a methyl group to THFA. And as we saw on the folate slide, so THFA is folate. Cobalamin and folate work together to produce healthy red blood cells and to convert homocysteine to methionine, thus reducing homocysteine levels. And then B12 is unique or different from folate in that it also helps maintain the myelin sheath, which is the protective coating around our nerve fibers in the brain. The RDA for B12 is 2.4 micrograms per day, and anyone experiencing atrophic gastritis would have an increased need for B12. Atrophic gastritis is something we commonly see in aging populations. Food sources of B12. So B12 is a vitamin that's produced by bacteria, and these bacteria typically live in the soil where food is grown. So there's the potential to consume B12 from plants directly if the plants have not been hypersanitized prior to consumption. So by and large, most of the food we're going to get out of the grocery store, most of the produce, the vegetables are not going to have much B12 on them because they've been so sanitized prior to arriving at the grocery store, and then even at the grocery store, a lot of times they receive extra cleaning before sale. Animals do not make B12, but because they typically live more close to the soil than humans do, animals are often exposed to these B12 producing bacteria by living in and rolling around in and eating very closely to the soil. Animals, including human animals, can store B12. So again, for humans, if we're eating animal food, animal liver is actually the richest source of B12. It's not generally stored in muscle tissue, but again, we don't often eat the organ meats. So B12 deficiency is an interesting one. Anyone, including vegans, vegetarians, and omnivores, can become deficient in B12, and we're actually seeing more of this, and there are working series that we're seeing like unanimous B12 deficiency because of our hypersanitary practices around food. So one potential way around this, again, potential, is for people who have access to grow some of their own food. Maybe there would be less concern to hyper-sanitize the food before consuming it, or even just working in the garden more. Potentially there could be a mechanism of absorbing B12, but those are sort of areas of research currently undergoing. So then food sources, if not liver, would be foods that are fortified with this nutrient. So many foods now in the grocery store are fortified with vitamin B12. And again, those are vegan foods and omnivorous foods alike. Again, you can just check the ingredients lists and you'll see if B12 has been added into it. Toxicity, there is no known toxicity for B12, and for that reason, then no upper limit has been determined. In the case of pernicious anemia, which is, we'll see on the next slide, what happens when there's a B12 deficiency, then monthly doses of 1,000 micrograms of B12 might be suggested as treatment. And so even at that level, there's no known toxic effect. But again, this is for someone who's already been super deficient in B12. So we're not recommending 1,000 micrograms monthly if you have adequate levels of B12. All right, so I think this is the only nutrient where we look more closely at absorption. But we do with B12 because it has a little bit of a complex pathway. So in the stomach, B12 binds with a molecule called R protein. And we're pretty sure that the function there is to help protect B12 from the acidity of the stomach. So R protein travels with B12 into the small intestine, and in the small intestine, enzymes cleave or separate R protein from B12, and then a molecule called intrinsic factor binds to B12. And this binding is critical for absorption into the intestinal cells. So for someone who's making an inadequate amount of intrinsic factor, then B12 absorption is going to be hindered. And once inside the intestinal cell, B12 is then transferred to a molecule called transcobalamin 2, which is a carrier molecule. It's a protein molecule, and it carries B12 in the blood from the intestinal cell into the bloodstream, and then transports B12 to different tissues, so liver cells, bone marrow cells, and developing cells elsewhere in the body. So three major steps are the R protein, the intrinsic factor, and the transcobalamin 2. Those three molecules are required for B12 absorption. Deficiency of B12 can be caused by lack of any of those molecules, so lack of R protein, lack of pancreatic enzymes to cleave R protein from the B12 molecule, and lack of intrinsic factor. Absence or removal of the ileum or the stomach, ileum being the first part of the small intestine, overgrowth of bacteria in the stomach, tapeworm, Both of these two things can either lead to like tapeworm could actually be stealing the B12 right out of our guts from us, and overgrowth of bacteria in the stomach. There could be multiple pathways there. It could inhibit the production of our protein, which would lead to destruction of B12 via the acidity of the stomach. And then also reduction of gastric acid production could also inhibit B12 absorption, and this would result from prolonged use of acid inhibiting medications, as well as atrophic gastritis. And then what I didn't put on here is that B12 deficiency can also just be caused by insufficient intake. So we said at the very get-go that water-soluble vitamins cannot be stored, and B12 is the exception to that rule. So B12 can be stored in the liver, in our liver, in human liver, and it can be stored for like even up to 2 years and potentially longer. So because of this, symptoms of B12 deficiency might not show up for even upwards of 10 years. So B12 deficiency is a really tricky one because we might be looking out for it just through monitoring symptoms and signs, but we could be deficient and not know it because symptoms might not show up right away. So when B12 deficiency is in full swing, we see pernicious anemia. Pernicious anemia can result from insufficient intake and from an autoimmune disorder that damages the cells lining the stomach, which inhibits the production of intrinsic factor, and so B12 can't be absorbed. This is characterized by tingling and numbness in the extremities, abnormal gait, cognitive changes and disorientation, dementia. And also what we see alongside that, or part of the cause of that, is because the myelin sheath begins to swell and break down because there's not enough B12 to maintain it. And so that causes brain abnormalities and degeneration of the spinal cord, which results in those symptoms. The good part is that this can be reversed with B12 injections. Even though that's a pretty severe disorder, it has somewhat of a cure